Are we ready?
We are.
Okay. Again, I will say welcome to everyone on the phone. Hopefully, our technical difficulties are out of the way and we can move things forward. Apologize for holding people on the line for this because I know we're board members are all busy people. So appreciate your being here, and Denisha, please call the roll.
Yes, Chairman. I'll begin with Norman Boyd,
Here.
Russell Crutchfield,
Here.
Cynthia Rucker,
Here.
Roger Folsom,
Here.
David Cruz,
Here.
Anthony Williamson,
Here.
Melva Lee,
Here.
Jane Mobley,
Here.
Robert Coles.
Here.
Chairman, that concludes my roll call.
Thank you, Denisha. Again, welcome to today's meeting. We have a quorum and I'll call the meeting to order. Opening comments, just to comment on the agenda. We have one item on the agenda today, but it's a very big item, and it's traditionally our second board meeting in the month of August each year is to consider budget. And today that will be the main topic of conversation and presentation, and we'll be asked as a board to vote on that at the conclusion. With that, I will turn it over to the Commissioner Carlson for his report.
Thank you, Chairman Boyd. I want to echo his sentiments to everyone out there. Thank you for staying with us while we work through that, and we will be sensitive to time. I'll move right along, Mr. Chairman. Want to kind of set the stage for today's second August meeting. As is the custom in the first August meeting, we take up our usual business, hear from our SHBP team about the upcoming year's rates, plans, and preparations for open enrollment, which is set to begin October 16th to our state employees and retirees out there, October 16th. As you all know, the department continues to focus on our day-to-day mission, working with families, providers, and our numerous partners to administer various services and supports. And as we all know, there's a tremendous amount of energy, focus, and thought that goes into the nationwide Medicaid redetermination effort, as well as the new pathways to coverage program and the large procurements pending before us here and now. But for today's meeting, we have a more limited scope. But don't let the short agenda fool you. There's a lot of significant information to be shared with you today. You'll soon hear from our Chief Operating Officer, Joe Hood, and his UGA socks, ready for action today, discussing both our amended 24 and fiscal year 25 budget requests. Joe and his team, as always, have spent several weeks scrutinizing every number in concert with our good partners at OPB and our sister agencies to present you, both the board and the public, an accurate and transparent snapshot of not only where the department is here and today, but a bit of a snapshot into health trends across our state. I want to personally thank the entire team for their work on this effort, their commitment to detail, and their teamwork. In addition to the updates on spending, growth, contraction across all DCH programs, budget presentations can also serve as a bit of a state of the agency address for large organizations like these. In that spirit, Joe will be walking us through some interesting proposals we at DCH have been working on for quite some time. Thanks to Governor Kemp and the legislature's strong fiscal management, Georgia's healthy economic position has allowed for agencies like ours to strategically assess how we might make use of a 3% enhancement to our budget. We thank the governor and OPB Director Rick Dunn for allowing us to do this. And as you can imagine, we just happen to have some ideas. In today's presentation, you'll hear proposals associated with performance management. There's no secret the CMO procurement that is before us here and now is not only a large procurement, a large administrative lift, it's also a significant health initiative for our state. It sets the tones for our priorities, desired outcomes, our aspirations for the future, our expectations for valued managed care partners. And sometimes these expectations of our partners can and should be set high. But while much of this procurement exercise revolves around what is expected of others, we at DCH also need to honestly assess what's expected of us. Ask hard questions about how prepared we are, how and where we need to grow in terms of not only human resources, but in areas like advanced systems, technology infrastructure, better data quality and integration, and improved analytics. In a planning process that began with the vision and leadership of Commissioner Novel and our vendor partners, we have been asking ourselves those hard, sometimes uncomfortable questions. As they say, venture outside your comfort zone and the rewards are often worth it. Simply put, the performance management portion of today's presentation will outline our intent to invest in ourselves, but in a strategic and fiscally responsible manner. And by doing so, DCH will be a better partner for our providers and payers, deliver better services for our families, and be a more efficient department on behalf of the Georgia taxpayers. So I want to thank you, Mr. Chairman, for the time, and I look forward to Joe's presentation.
Thank you, Commissioner, and thank you for setting the tone for today's meeting and the importance of the discussion that we're going to have. And I've clarified with Joe as I turn it over to him, Joe Hood, our Chief Operating Officer, that questions during the presentation are certainly in order. Joe, please.
Thank you, Mr. Chairman. Commissioner, board members, thank you for the opportunity to present the department's amended fiscal year 24 and 25 budgetary requests that we'll be submitting to the Governor's Office of Planning and Budget for consideration. As you can see on the agenda today, we have the 23 budget highlights that we're going to review to show you basically how we ended the year with expenditures across our programs. Then we'll next go to our current budget and how we've started and how that looks from a big picture across all of our budgetary programs. And then we'll get into the heart of our presentation today in the amended fiscal year 24 budget request. And following that, the fiscal year 25 budget request. And then lastly, we'll give a status of the state health benefit program financial.
Joe, just so I understand, you're someone that doesn't work with this all the time. The fiscal year 23 budget highlights, we're talking about 23 having ended on June 30.
Yes, sir.
Right?
The 23 is July 1st of 2022 right. Through June 30th of 2023.
And 24 beginning July 1.
Yes, sir. Our state fiscal budget for 24 that we are now in started July 1st of 2024. That was passed this past session.
The budget things that we're going to hear about are what we will be asked to vote on. The state health benefit plan financial status is information only at this point. Is that right?
Yes, sir. That's correct.
Okay. Fine. Go ahead. Thank you.
Thank you. So turning to how we've ended the year for state fiscal year 23, we have a pie chart and the programs are to the right. And you'll see that we had $21.7 billion in total fund expenditures, of which almost $4 billion are in state fund expenditures. And if you look to the right, you'll see that our largest program is age, blind, and disabled at $8.1 billion, low income Medicaid or the CMOs at $7.7 billion, the state health benefit plan at $3.8 billion, Indigent Care Trust Fund at almost $1 billion, Peach Care at $500 million, the Department of Administrative and Program Support at $542 million. I did want to pause here and just for those who may have some unfamiliarity with the budget process and how this is structured. These other programs are largely benefits. So when you look at our administrative and program support, all of our Medicaid staff, state health benefit program staff, all of that is contained within the Departmental Administrative and Program Support, including our Medicaid contracts. So for example, we have some of our larger Medicaid projects, such as the the pharmacy benefit manager, GAMIS, which is run by a vendor. Some of those are huge contracts. The GAMIS, for example, approaches $100 million annually. So when you think about that, that's all of the administration for Medicaid and all the personnel generally for the department that's contained in that one line. Everything else, for the most part, is a benefit program and paying benefits. Moving next to the Healthcare Facility Regulation Division, that's $37.7 million. The Healthcare Access and Improvement is $34 million, but there again, this is a grant program. This is the Office of Rural Health, and this contains a lot of the federal grants that they distribute, and it also has the small staff that they have, but it's largely grant-based. Lastly, we have our pharmacy and dental boards at $1.6 million. Moving next, this pie chart concentrates just on the state funds and gives you an indication of the subset of the state funds for the almost $4 billion that we spent in 2023. You go forward, as a breakout, we have the percentage by each major program. SHBP, the State Health Benefit Program, is 19%. The Age Blind and Disabled is 17%. And the Peach Care for Kids is 6%. And of course, our largest program, Low Income Medicaid, is 58%. And that's broken out to the side to give you an indication of what is managed by the care management organizations: 74% children, 11% pregnant women, and then low income caretaker at 15%. That's primarily in the care management organization's budget and low income Medicaid. That represents 58% of the total, which I think is a big thing to take in consideration given the commissioner's comments and what we're going to talk about for oversight of CMOs, and you see why that's such an important part of our budget and the large percentage that it takes today. Moving next, we have an overview of rate increases. And you'll see later in the presentation that rate increases in utilization really are a driving factor in our budget. We wanted to highlight the legislative changes where they've supported us with the governor for rate increases in the past year. We've had a 10% reimbursement rate increase for long-term acute care in hospitals and inpatient rehab facilities. We've had a 5% reimbursement rate increase for mechanical ventilators. And then we've had an increase in the reimbursement rate for home and community-based service providers to offset the cost of fingerprint requirements. And then we've had an increase in reimbursement for medical nutrition therapy, and then a 10% increase in 2 dental extraction codes. In total, we have $4.2 million in this year for rate increases and a total budget of $12.9 million. And this is only in our age, blind, and disabled fund, in our fee-for-service side that the department manages. Moving next, you'll go to the low-income Medicaid, and those same increases for medical nutrition therapy and dental extractions were replicated there in the CMO budget for a total of $2.2 million. And then lastly, those same 2 items again were replicated in our Peach Care for Kids for a total of $82,000. Overall, we have $15.2 million in rate increases for this particular year that were added recently by the legislature in 23. Next, we're going to move to our current budget.
Am I correct here if I look at these numbers? Legislature approved these rate increases, and because of the rate increases, we were able to access additional federal funds. Is that what this tells us?
Really, what this tells us, Mr. Chairman, is these are the rate increases that were put into effect in state fiscal year 23 as a result of the session. So they either opened a new code, as for example with the dinner, with some of these, or they added 5 or 10% to the existing rate. And the real reason that we're pointing this out here, other than just to make sure that you have awareness of what the increases were, is these are driving factors when we get to the budget that you're going to see in a minute of why we have increases overall in the upcoming years, because we're not at a status quo. We're always in each legislative session adding a percentage of increase of one way or another, or we're adding a new service. So it's really a combination of those 2 things and these different programs that are reflected here.
Thanks, Joe. Thank you.
If you move next to our current budget that started July 1st in 2024, you'll see that it's $19.6 billion. In this budget, you have the same programs to the side, the age blind and disabled at 7 billion, low income Medicaid at 6.1 billion, state health benefit plan at 4.8, indigent care trust fund, which provides matching funds at over $500 million, Peach Care at over $500 million, and then the administrative program support again at $493 million, and then healthcare facility regulation at $39 million, healthcare access and improvement, or the Office of Rural Health at $19 million, and pharmacy and dental boards at $1.7 million. You'll note that some of these numbers are less, and that is because we're going to next talk about our amended budget to this base budget that was put in place in the past legislative session, and it will naturally have increases in the benefit programs and any changes that the legislature or the governor make as we move into this next session. If you go to the next slide, it concentrates on the state funds budget that are in state fiscal year 24. And you'll note that this is 4.6 billion as compared to 3.9 billion that we covered in the ending fiscal year 23. I want you to note that largely, and I'm going to point this out when we get to our amended 24 and 25 budget, particularly 25, that we're having a change in our FMAP, our federal medical assistance percentage that contributes to Medicaid. Our FMAP has been enhanced during the pandemic at different rates. But as we have come out of the pandemic, we're having a shift. And that shift is that we're having more state funds that are required for the same services and less federal funds. Those federal enhanced funds are going away because the pandemic has ended. And you can see that directly when you look at the comparison of the 3.9 billion that was in fiscal year 23. And now when we get to 24, we're at 4.6 billion in state funds. But as the chairman noted in some of our pre-discussion, the actual total funds is less in this budget at this point in time. It's 19 billion as compared to a larger number in 23. And that is all due to the shift in the federal medical assistance percentage and not so much to individual utilization rates. And you're going to see more of that as we move forward into our request. In this budget, you see increases, for example, in age blind and disabled over 300 million on state funds as compared to 23, and over 300 million in low income Medicaid. Those are the large drivers on these particular programs in 23 as compared to 24. Moving next to rate increases that happened in the base budget for 24 that were approved and are now a part of our 24 budget. We had a change in age blind and disabled in the fee for service to increase funds for reimbursement rates for developmental and behavioral screening and testing. And this was repeated in our CMO budget in low income Medicaid and again in Peach Care. Overall, this is a small amount, 82,000 for this particular year for age blind and disabled. And then additionally in the CMO budget, we had a $1.7 million in total funds increase to remove the 5-year waiting period for pregnant women and children who are lawful permanent residents. Overall, these rate increases represented 2.3 million in total funds that were added in fiscal year 24. Next, we're going to move into the heart of our presentation, as I mentioned, the amended fiscal year 24 budget request, where we're asking for the governor and legislature to consider additional money to be added to our current present year budget, where we see changes that most likely will occur throughout the year. This slide is a summary slide that I'm going to speak from to explain the budgetary requests for each program. Across the top, you have our major programs. ABD is age blind and disabled, and that's in our fee for service. LIM or LIM is low income Medicaid, and that is largely our CMOs managed population. And then you have PCK, which is Peach Care for Kids. And then you have the total budget request by line item that is being requested for the amended budget. If you first look at the top corner, you'll see that enrollment is a number that we're projecting an increase in the age blind and disabled of $36.7 million. But if you move across to the low income Medicaid or the CMO managed care, we're projecting a $130 million decrease. As a reminder, as we come out of the pandemic, our member enrollment was at its highest level because we have not terminated any members during the pandemic. But as we begin the redetermination process, we'll have a natural decline, and this is recognizing a portion of that decline in amended fiscal year 24. Going further to the side, we'll have Peach Care for Kids, which is 13 million. Going back to LIM, I do want to point out, and I'll talk about this as we get to other parts. The largest change you'll see is the utilization and rate changes. And that's why we specified earlier of those that were added. But you'll see 375 million in LIM in the CMO budget is the largest increase that we project. And it's not driven by growth. As you see above, we're projecting that enrollment is going down as a net. But I did want to point out that's a net. We've got folks who are coming off, and then we've got folks who are coming on from pathways and from other sources. We had a number of initiatives to bring people onto Medicaid. One in particular was joint enrollment with SNAP and TANF through the eligibility system. And then we extended coverage to mothers from originally we were only at 2 to 3 months, and now we are for a whole year of postpartum care. So there are a number of items that increase enrollment in this number, and also with the end of the pandemic decrease enrollment. And this is the net result of those. As of the end of May, and I want to make sure that that's clear as well, is we have to prepare this and have it as a part of a projection process for the governor's estimate for the revenue that the Governor's Office of Planning and Budget prepares. So in the spring, that's when these are prepared, and we have to do that at the end of May. So everything that you see here is a projection for amended 24 and 25 at the end of May. We will continue to work with the Office of Planning and Budget in the future as we get better enrollment numbers and have a clearer picture. But as of the September 8th submittal, this is what we're recommending will move forward as our best estimate for projections to date. Overall, at the bottom, you see the numbers that we have for each of our programs. In addition to the enrollment and utilization that I've referenced, we also have Medicare Part D premiums and Medicare Part D clawback. And this is in our fee-for-service line only. As you may know, we have dual eligibles within our department who are on Medicare and Medicaid in the fee-for-service. Each year, the federal government will have increases, as many of you also know from your own lives, if you're on have Medicare coverage, that Part B premiums and Part D for pharmacy, the premiums increase. So as part of that, for us to maintain the duality, we pay for those benefits and the increased premiums, and this is a reflection of that increase. Those only occur in the fee-for-service because the rest of the population are children in Peach Care for Kids, or they're in managed care in low-income Medicaid. The line below that reflects the $73 million across all programs that we'll capture from drug rebates. After that, we have one of our largest items, which is the Nursing Home 2021 Cost Report. You may recall that for the first time, the legislature has gone to a cycle of where they've requested in the appropriations document that we update the nursing home reimbursement rate to the most latest cost report for each fiscal year. This is a reflection of the first year that will occur, and the cost of that is estimated to be $111 million in state funds. The next line item is IBNR. It's incurred but not yet recorded. So as we're referencing, Mr. Chairman, the fiscal year ended June 30th, 2023. However, we still have claims that occurred in that past year that we were not billed for or not yet recorded on our financial books. So that's incurred claims, but not yet recorded on the financial statements. And we will continue to receive those bills throughout the upcoming year. And what we do at the end of the year, we have an amount of funds that is there for reserve to pay these claims. And that's what's referred to as IBNR. And we reserve those funds to pay for claims that occurred the prior year, but are coming due in the current present year. This amount is a reflection of where we did not have sufficient funds to reserve the total amount in 22 for 23 claims, and we're bringing that forward to reflect that we believe we're going to need an additional amount in 24 to pay for 23 claims. Now, again, we'll continue to work with the Office of Planning and Budget and look, because we'll know in July, August, September, so come October, November timeframe, we'll actually know what we paid in that first quarter of this year for claims from last year, and that will allow us to better define this number in the future. But right now, this is our best estimate that we'll need an additional $60 million in state funds. The last item here is pharmacy. We have $37.3 million that's identified in pharmacy, primarily in fee-for-service. And the reason for that is there are a number of new drugs that are forthcoming that our pharmacists have identified that they believe will be cost drivers. Some of them are very costly. And as a combination, looking at the population that is in fee-for-service and identifying the population that we believe will have utilization of those drugs, we believe we'll have new spend of over $37 million related just to a handful really of new drugs that are forthcoming. Overall, this gives us a request of $531,876,428 that we're requesting in the amended budget that would be forthcoming for the year that we're in today. I'll pause there. And next, we're going to move to what the commissioner talked about in his opening remarks, and it's really the first part of this. This is the first time in a long time that we've been given the opportunity, both in the amended and the big budget, to ask for new funds. And they've given us the opportunity to ask for one-time funds to do new initiatives. So as a part of that, with the work that we've done with consultants and others throughout the past year in preparation for the new care management organization request for proposal that will soon be out, we have worked with consultants to also look at our oversight of CMOs and really understand how we compare to other states and where we could do better in an oversight capacity, and really build within the department to provide better oversight in the future. And we see this as an opportunity to really transition and build the team that we would need to do the appropriate data and analytics to be prospective. And we're going to see that request in the 25 in the base budget in a staffing request primarily. But here in the amended budget, we're asking for $7.2 million to assist us in consultants and contracts to make that transition. When I get to the 25 request, you'll see the overall scope of what we're asking to do, but we're going to need assistance in order to affect this change and to place people organizationally and to come to a true place where we can do prospective data analytics for program management of Medicaid. And this is our request as a one-time item to provide us contractual services to make that change probably over a 24-month period, because as y'all know, we'll have the request for proposals and we'll have the management of those CMOs, and that will really come to bear as we award new contracts at the conclusion of that RFP process. But this $7.2 million is our first opportunity in some time to ask for new funds. These are one-time funds, but again, we would stretch those for the project probably over up to a 2-year time frame. Next, I'm going to move into our fiscal year 25 budget request. So this request, to your point, Mr. Chairman, would be starting July 1st of 2024 to cover the period July 1st, 2024 to June 30th, 2025. And it is the same setup that we had and the same items for the most part for the amended budget. We have enrollment for age blind and disabled of 109 million, utilization rate changes that are decreasing in age blind and disabled for 25 of 42 million. Then we have FMAP restoration, loss of enhanced FMAP, and a change for FMAP as a combination. And I really wanted to highlight this portion across all programs. Those three line items, if you go to the far right, 273.3 million, 151.5 million, and then 5.9 million in FMAP. They represent almost 40% of this budget request. And they are all due to FMAP changes, or federal medical assistance percentage, that is changing. And I alluded to that earlier when I pointed out the difference between 23 and 24. But here, particularly in 25, this is the first year where we have no enhanced federal medical assistance percentage for the particular year. And over 40% of this $1 billion increase is due simply to a change in how much state funds we have to provide versus how much federal funds are provided for the 25 budget. Looking below that, we have the Medicare Part B and D premiums again in 25, and these are projected at additional increases given that time frame, just as they were in 24. We again have drug rebates that we expect of 94 million across all programs. And then we have the 22 cost report for 25. You'll remember in the amended budget, we reflected a 21 cost report. As we come forward to 25, we'll be updating to the next year's cost report. And we project that that is an additional $98 million that would occur in the big budget for 25 to go to that cost report for all of our nursing home reimbursements across the state. And there again, in the last line, we have pharmacy that is reflected again, and it's the same thing basically in fee for service, where we've identified drugs that we believe are going to be high cost for those fee for service members. If you look on the page, the largest item on here that's driving the billion other than FMAP is the 341 million in utilization and rate changes that is in the low income Medicaid portion, or the CMO managed care. And that's our largest population. And it's really the utilization and the continued rate changes of where we're increasing reimbursement that is driving that for the $341 million. Between the first two lines, enrollment and utilization, that accounts for 43% of the $1 billion. And then the FMAP is about another 40% of our request. And then we have the other items that I referenced for Medicare, drug rebates, nursing home, and pharmacy to get to our total budget request of $1 billion. And I will emphasize again that this will change as we move forward and we have better understanding of our utilization and enrollment. This was as of May, the end of May, and we'll continue to work with OPV as I've stated, and we'll have much better information as we get into the fall. Next, I'd like to move to what we're really happy to talk about and really excited about, and the commissioner referenced. In conjunction with the amended request of $7.2 million, we have the opportunity to enhance our base budget by 3%. And the majority of that, we're going to concentrate on data and analytics. We've worked with consultants and they produced this slide as a summary of what we would like to do. We would like to have strategic direction for our oversight of care management performance. And what that means, referencing back to when Commissioner Noggle was here and what she had really visioned for data and analytics when we started talking about this with our contractor, is we want to be prospective. We would like to have data and dashboards that allow us to predict where we're going into the future on any individual item and really be strategic in that direction and not be just reactive, where the legislature passes a rate increase and then we analyze how much that cost and we give that number. We'd like to be looking at trends in advance and being able to prospectively have those for the governor and for the Office of Planning and Budget and the legislature, and not just on the back end. And that's really the strategic direction. But in order to do that, you have to have talent and organization. We've got to have governance, staffing, roles and responsibilities, largely in data and analytics, but you'll see in a minute when we outline where we want to ask for additional staff, is really across the spectrum in Medicaid policy, finance, and IT to have a total grouping that gives us talent and organization to prepare prospective statements and have the data available. The third column is data and information. I mean, largely we have to have data sources that are utilized and brought together and formatted into timely data that we can utilize to do prospective analysis. That data has to have good quality. It has to have integration and enrichment and data governance. And we're really just now reaching a place where we're cloud-based, and we worked with our internal staff to get to a place where we believe with the expansion of staff and resources, we really could do dashboarding and prospective analysis given the opportunity. The next is technology and architecture. And this is simply continuing to do the things that we've done in the last couple of years and moving to a staff-driven model with technology and architecture in the cloud and moving away from a contractor. We have IBM today as our primary contractor for data and analytics, and moving it to a staff-driven process that's in the cloud and cloud-based and managed by the department. And this is a continuance of that, but it's shifting not only from our regular operations that we do today, but then adding this additional component so that we could be prospective and do policymaking. Lastly is analytics and reporting, and that's simply the reporting out and using all of those functions that we've covered in 1 through 4 to come up with prospective reports that can be presented to executive leadership, the governor, and the legislature to make decisions into the future. And of course, the execution is the culmination of all those factors together that allow us to do that. If you flip to the next slide, this is the primary component of what we're asking for on the 3%. And as I referenced earlier, you'll see what we're asking for is a total of 49 new positions or 2.8 million in state funds that would be matched at 50% with Medicaid funds for a total budget of 5.6 million across many areas. We projected with consultants and discretion that we've looked at that we would need 6 provider network positions, 5 member services positions, and those are in Medicaid policy. So that's working prospectively with new positions that can look and think about policy making prospectively, not just the general operations, which is what we do today. And then we have so that's a Medicaid total of 11 positions. Then in IT, we have a total of 30 positions. We have 18 analytical positions that we're requesting, 9 data positions, and 3 data quality positions. And that is really the bulk of this request, as you can see. But lastly, we also have a finance component of where we're doing cost and utilization analysis, and then executive leadership to assist us in this new policy initiative of 2 positions. All total, that's, like I said, 49 positions or $5.6 million. This request was not established in a vacuum. So we have looked at comparison states who are already implemented in this same fashion, and that's how these numbers were driven in consult with a contractor to come up and show that we're under-resourced for a state of our size for care management organization oversight. If we want to be prospective and better manage CMOs in the future, we believe that we need to add this type of staffing component to be competitive and comparable to our other states. Predominantly, we looked at the state of Louisiana, who has implemented this, and that was the consultant's primary example that they showed us that their staffing component for CMO management was much more robust than what ours was. And then we have the comparison and the net differences that drive this request.
Joe, can I say something here?
Yes, sir.
This is a great example of planning and planning a strategy for the future. And you're adding resources in the way of people you're going to have. But historically, in experience in the private sector anyway, a lot of strategic plans fail because they don't have the capability within their human resources with the people to execute the plan. And I would encourage as advice in departments making sure they have the qualified people, not just people, but people that can actually do the execution.
And certainly, Mr.
Just a
Chairman,
statement.
that will be the challenge if we're successful in achieving these positions in recruitment and retention of those positions. I will say that we've had great success in partnerships with Kennesaw State, with Georgia Tech, and our new leadership in NIT with under Chad Purcell that he's brought on. We had, I think, over 10 graduate students that came through this past year that worked diligently. And we do think we have a good recruitment process to bring those folks who are interested in serving the public and working in this area if we have the opportunity to add additional positions. So we're really excited about the opportunity, but certainly you're correct that we have to find the right folks, right? Those who want to work in public policy and government service and also have the right qualifications to do this type of work.
Hey, this is Shane. My question is that, yeah, are these salaries high enough? You know, you start talking about Georgia Tech grads and some of these other things, you know, I think we need the positions like the chairman said, but, you know, I'm looking at some of these analytics and data quality, you know, a lot of these jobs they can do remotely and make 40 or 50% higher. So, you know, do you guys think that you set the average salary high enough to be able to get the quality people you need and that they're not going to just come on and get that experience and then leave?
I appreciate that question, sir. And so for context, these salaries are what the state pays for these types of positions today. So they're based upon departmental salaries of people that we have in place for our regular operations today. And certainly we're limited to the 3% as well. So a reminder of that, we can only ask really at a maximum at this point for this amount. So this is really to start that conversation. And I think you're exactly right. It may be that as we move forward and we fine tune this, that we have to make adjustments, but this is what we pay our staff today. And we have that challenge today. We'll have turnover and we'll bring in those new graduates from Georgia Tech and from Kennesaw, and we'll start again. But we do get a lot of value by trying to do that recruitment effort. But unfortunately, just like everyone else with these salaries and with that challenge, we do have turnover, and we recognize that that will be a challenge going forward.
Thank you.
With that, I want to turn to another area of recruitment and retention, and the remaining part of our 3% enhancement. We want to focus on Health Facility Regulation Division. As you may recall, the Health Facility Regulation Division oversees the licensing, the complaints, and regulatory aspects of all of our healthcare system facilities throughout the state of Georgia. Most folks think about nursing homes because that is a large portion of what we survey and oversee in HFRD, Health Facility Regulation. But we also have all the hospitals that we have oversight for. Any healthcare related facility, such as assisted living, which is a state licensed entity, all of those entities have oversight in HFRD. And the main component part of that oversight is our surveyors. Our surveyors go out and they do complaints, they do recertifications of facilities, they do all aspects of the direct oversight on site of these facilities. And the recruitment and retention of those surveyors is a prime challenge for us and has been for many years. But as we move out of the pandemic, we see some of our sister states, again, looking at Louisiana in particular, where they've got 76,000 in comparable duties for registered nurses as a starting salary. We are behind the curve on that, and we believe that we should focus a portion of our 3% to the extent that we can. Honestly, what we've done is this is the amount of money that we have under that 3% cap to raise salaries. It allows us to go to that 7%. There's no magic in the 7% other than that is what we have the ability to request. But if we did that, that will put us much closer to some of those sister states that have been raising surveyor salaries, and certainly allows us to try and keep pace with the market. I think Mr. Mobley's reflecting on IT and the healthcare facility. You know, we're not competitive. We still have to identify folks who want to serve, have government service, and be in this role, but we need to be, you know, closer to the market rate, and this gives us some opportunity to do that. So we're asking for 1.2 million for all of our surveyors. So these would be state licensed surveyors, nurse managers, regular surveyors for nursing homes and different healthcare facility or different healthcare qualifications. It's across the spectrum, including our regulatory managers and our quality assurance specialists. Next, we're going to move to the last scenario that we've been asked to prepare by the Governor's Office of Planning and Budget. They've given us an opportunity to ask for 3%, but they've also asked us to identify anything that we're aware of where we could reduce our budget by 1%. So what we've chosen to identify is, and what we think is really the most effective way that we could take a reduction, is as we transition our GAMMA system in our Medicaid Enterprise System Transformation Project, which has been ongoing for 5 years, we believe that we will see efficiencies of the $1,372,082 by the time we reach 2025. That can be a matter of a variety of factors, including utilization within the system, the technology advances that we hope to achieve, all those things combined of different factors, we believe that we'll be able to achieve that reduction in state funds in 2025. So we're putting that forward as our recommended 1% reduction. Mr. Chairman, that concludes the Medicaid portion and the budgetary request. And I can move into the state health benefit plan, but really this, I want to make sure that we answer any questions before we do the last
Let's answer
slide.
questions on this and then you expect us to take a vote.
Yes, sir.
Okay. Addressing the board, are there questions or comments related to Joe's presentation on the budgets?
Mr. Chairman, this is Roger Folsom. I just want to compliment Joe. That was one of the best analytical presentations of the budget, I think, since I've been on the board, and I'm very appreciative for it.
Thank you.
Any other comments?
Mr. Chairman, David Cruz, I wanted to ask Joe a question on his first slide for FY 2025 budget request. The utilization rate changes for ABD, the reduction there versus the increases for the other categories. Could you speak to that difference?
So the age blind and disabled population is much more stable than the other populations. And so really that's the management of that population. And we do expect some enrollment changes in age blind and disabled. I really think that's going to be a reflection of those enrollment changes and the reflection of utilization there. And again, I want to remind you, this is as of May. So as we move forward and look at that first quarter, that may change. It may change to a positive number where we actually have a request. But the actual, in concert with the actuaries and looking at that population, they believe that there's going to be a decrease due to enrollment and utilization. There's not a particular thing or item that I'm aware of that I can point to that's going to drive that. It's really a culmination of many different factors. But the big point that I would like to make there is that ABD is more stable as compared to that limb population where you're going to have some growth in utilization to some extent. I'm sorry I don't have a better explanation for that for you on that particular point.
Any other questions, comments from the board, please? Hearing none, is there a motion for approval for both of the presentations for amended 24 and for fiscal 25 budget?
This is Dr. Lee. I make a motion to approve.
Motion's been made for approval. Is there a second?
Russell Crutchfield will second.
Crutchfield is seconded that. All in favor say aye.
Aye.
Aye. Opposed? Abstaining? Hearing none, it is approved, Joe.
Thank you, Mr.
Thank you
Chairman.
very much. Can I just ask you to do one other thing with this, just for our information and going forward, and some of the people that aren't as familiar, or haven't been through this in the past, what is the time frame as you move forward with this?
Absolutely.
Presented to the governor's office, to legislative, so on.
Yes, sir. So what will happen is we will now submit this budget request. September 8th is our deadline for the formal submission to the Governor's Office of Planning and Budget. And then we will continue to work with the Governor's Office of Planning and Budget through the fall as they develop and do their own analysis and come up with a governor's recommended budget. They'll work with the governor's staff, their policy staff, and all the folks throughout to come up with a final governor's recommended budget that will come out in January. And then that January budget will be presented to the House and Senate, and the House will generate two budget bills that will start, one for the amended bill for the present fiscal year and one for the big budget for the next fiscal year 25. And they will move that forward and will present in a joint hearing in response to the governor's budget and to what we presented here will be our first hearing to the legislature. And then we'll have a House hearing, a Senate hearing, and then a conference committee on each of those budgets. So a total of 6 plus the joint to form these budgets. So the amended budget, we expect generally that might pass in late February. They'll do that one first because it's the year that we're in. And generally those changes impact the last quarter of that fiscal year. And that's what we would expect. And then for the bigger budget, that generally passes at the end of session, many times on the last day or last week. And then the governor will sign that typically in May. And then of course we will have the impact and start all those processes in July. I did want to point out one other thing that before we get into SHBP, many providers out there might have thought that we would have a request for rate increases because we have had 3 rate studies, 3 or 4, depending on how you count it, with our partners at the Department of Behavioral Health and Disabilities. And we've worked with actuaries and others throughout the year for House Bill 1013 that concluded. And those rate studies are still much under consideration. I want the providers out there to understand and know that just because that's not reflected in the departmental budget request, that is not a reflection of what is under consideration in partnership with the governor's office and the legislature. And we fully expect that we will have a recommendation in regards to those rate studies. And the reason I say that is those are several $100 million in contemplation, and they need to be considered across the different departments. And that's a job that the Office of Planning and Budget will do. But I also don't want the providers to think that because that's not seen in these budget requests, that that's anything that they should indicate that that's not going to occur, because that's not our understanding. We'll continue to have those discussions and finalize those rate studies. And we expect that the governor will have consideration for that in the upcoming year.
Thank you for that, for adding that, Joe. Very good information. Okay, please go to your state health benefit plan update.
So this slide is to give you an understanding of the status of the state health benefit plan. As you may recall, the reason that this really isn't in our budget request is because we received this revenue from the different entities that are appropriated by the legislature, primarily through a per member per month flat rate fee that the school systems assess each member who participates in the state health benefit plan, and then an employer rated percentage of payroll for the state portion for the state agencies that are part of state health benefit plan. Those are 2 separate funds that are represented. And on our financial statements, if you were to look, you would see that they're represented separately and distinctly for revenue and expense. The state portion is a state fund, and it has a related OPEB or other pension employment benefits that's related to the state employees. Those who are participating in the state health benefit plan who are in the school portion, who pay a flat per member per month fee, are on the school side, and they have separate revenue and expense, and they have a separate school OPEB fund that's reflected in our financial statements. And then we have separate other pension employment benefit reports that are prepared by actuaries each year. None of that flows in a direct appropriation to us. We receive that, we assess the fees and we receive those, and that's why you don't see those. We record those as other funds and they come into us on a cash basis that we pay expenses as we receive them for the state health benefit fund. So when you look at this and you're looking at the total revenue across from 21 to 25, this is a combination of the school fund and the state fund combined, because it's much like your family checking account, at least for mine. All our money is in one big checking account, and then we pay the expenses out, and that's what we do here. And at the end of the year, we prepare financial statements that breaks that out and does the OPEBs. But this is the consolidated revenue versus expense. And what I primarily want to note is if you see that we started in 21 amended or 21 actual, the A is for actual, we had 3.6 billion in revenue. Then as you go to 24, 22, you see that's 4 billion. And then 23 is 4.2 billion. And then when we get to 25, we're at 5.2 billion in revenue. That's a difference of 1.6 billion in revenue. And that's primarily due to the legislature and the governor supporting us in a large increase in the PMPM for the school fund to bring them more in line with the revenue side. And that happened this past session, and we're very successful and grateful for that inflow. If we had not had that inflow of revenue, you would see that we would be in a place of a negative with the expense, for example, being in fiscal year 24, 4.6 billion. We would not have enough to cover in revenue if we had not had that inflow. Even still, you'll see by the time we reach 25, we have a net surplus of only 319 million. The further you go out, the expense begins to overtake revenue again. And we continue to have discussions with the Office of Planning and Budget and with the legislature on right sizing between the school and the state. Because even though you see the consolidated budget, it's much like my family budget. If you look at my kids' checking account independently, it's in the red sometimes. And unfortunately, that happens in the out years on our schools. So we need to right size that and make sure that we've got sufficient revenue in school to cover the school expense. And the main reason for that is our OPEBs. And what's not reflected here is we have normally the responsibility to make an OPEB payment every year into the school fund and into the state fund. We have not made an OPEB payment due to the pandemic in the last several years. But coming forward, we'll have to be in discussions with the Office of Planning and Budget about how much to make for OPEB payments into each of those funds. And that will further reduce our fund balance on this 319 million in 25. Ideally, we might make a couple of $100 million contributions in 23, 24, and 25. We really have to work what the appropriate amount is with everyone and make that determination. But that will significantly change our net surplus and deficit. And that will leave us with a much reduced reserve operating balance. When you look at the OPEB fund balance, I do want to point out many folks don't understand that is much like a 401k plan. If you think about that, that is a reserve that is out there. It's invested. It's not something that we can utilize readily. It's something that we put on our bond disclosure to show that we have enough capital to cover other pension employment liabilities. It's a financial obligation that we have to make, but it's not something that we readily have access to. And in fact, if we did actually sell those securities and start to use them, that would call into question our viability on meeting that obligation. So really what we have is the reserve operating balance that's available to us. And from that, we have to make a contribution into that OPEB balance each year now that the pandemic has ended. So we expect, that from that 1.6 billion in 25, that, we may have reductions. We just ended 23, so we still have the opportunity to make an OPEB contribution for fiscal year 23, 24, and 25. So if, there's substantial contributions that could come out of that and drive that to a lower amount. But overall, you'll see that we are in a positive place, and that's due to the legislative and governmental support of that increased revenue. And if you remember or you look back at past presentations, there was a lot of red in out years, and there's not red, at least for the for the near term for our coming two budget cycles for this budget, which is very exciting, although we still have work to do to right size between the funds. But that's our overall status for our state health benefit plan. Happy to answer any questions.
Any questions, comments from the board, please? Hearing none. Joe, we appreciate very much your very detailed presentation this morning.
Thank you, sir.
Does anyone know of any new business that needs to come before the board at this time? Hearing none, we are adjourned. Our next meeting is September 14th, and thank all of you for your time and participation this morning. Have a good day.
Thank you.
Thank you.
Thank you.